everyone who's joined the call. It will be 2 minutes before we start to speak. The registration form is in the chat, and if you're like me, I find it very difficult to listen and type at the same time. So for those of you who are already on the call, and if you are going to require one CME point, I would suggest that you fill in the registration form now, and we will then start what will hopefully be the beginning of a fantastic 2024. Our theme for this year is African solutions for African problems, and we are going to encourage constructive controversy. So please do fill in your names, and we will start the session in 1 minute. Thank you. Good evening, all. Pride, can you stop the music? Good evening, everyone. My name is Dr. Jackie Stone. I am the Medical Director and the Clinical Lead for Research and Development for Intellectus Campus. And I welcome you all to our first session of 2024. And we are very privileged to have a Zimbabwean doctor who works in Namibia, Dr. Enos Moyo, who will be opening the year. And as I mentioned a little bit earlier, our theme for Intellectus Campus for 2024 is African Solutions for African Problems, and we are going to encourage constructive controversy. So many years ago, when I was still at school, which was 1983, I hate to say, and most of you were probably born after that, but we had a debating society, and the object was to debate and to have an argument, which was not necessarily heated argument. It was an exchange of ideas, and a conclusion could come out of that. And that is what the scientific method is truly based on. So I'd really encourage you. I know there are people on this chat who are very involved with HIV, and we're going to start with community responses to HIV. And I will introduce Dr. Enos Moyo, who is a seasoned HIV specialist and an adept health economist, boasting an impressive track record of over 2 decades as a distinguished medical practitioner. Armed with an MBChB degree from the University of Zimbabwe, Dr. Moyo has relentlessly championed the cause for healthcare excellence. Fueling his ambition for leadership, he secured a Master of Business Administration from the esteemed Regent Business School in South Africa. He further fortified his expertise with a Master of Philosophy in HIV and AIDS. Management from HIV/AIDS management from Stellenbosch University. He has a Master of Public Health from the University of Johannesburg and a Master of Science in Applied Health Economics from the acclaimed University of South Wales in the United Kingdom. And reading this bio, Dr. Moyo, I think there are probably more letters after your name than are in them, which is extraordinarily impressive. Dr. Moyo's commitment to continuous learning is evident through his arsenal of postgraduate diplomas in business analytics, clinical pharmacology, and clinical research. And he is currently in pursuit of a PhD in public health at the University of KwaZulu-Natal in South Africa, showcasing an unyielding dedication to pushing the boundaries of knowledge. Cementing his reputation as a thought leader in the field, Dr. Moyo has also contributed significantly to the scientific discourse with 27 peer-reviewed journal articles published in top-tier international journals His body of work spans diverse topics, including HIV, AIDS, public health, infectious disease, maternal and child health, and health economics. Additionally, he has left an indelible mark through impactful consultancy projects for eminent organizations such as the Malaria Consortium, International Organization for Migration, UNICEF, and Project Hope Namibia. Notably, he spearheaded the revision of the Namibian Sexually Transmitted Infections Guidelines, which is a testament to his influential role in shaping healthcare policies, and he's currently stationed at the forefront of healthcare as a vital team member in Oshakati in Namibia. So, Dr. Moyo, I hope I have done your bio justice, and I've actually left some of it out. So congratulations on having such an awesome bio, and we really look forward to you presenting to us, and I'm handing the floor over to you.
Thank you, Dr. Jackie, for the introduction. Welcome, everyone, wherever you are. Today, we'll be talking about community-led interventions. I'm going to share my screen. Okay. I hope everyone is seeing my slides.
We can see them perfectly, and you're on screen share, which is great.
Okay, thank you. Right. So the structure of my presentation will be, I'll be looking at the introduction, the advantages of community-led responses, the community-led response activities. I'll also look at, I will have to stop my video because I think my bandwidth is a bit on the low side. We'll be looking at community-led response activities, barriers to community-led responses, community-led responses that have been implemented in Southern Africa, community-led responses that the outcomes of community-led responses implemented in Southern Africa, the take-home messages, and the references that I used. The presentation was supposed to be given last year before the World AIDS Day, but because of the commitments that I had, I couldn't manage, and I was asked to present it this year. So over the past few decades, there's been significant progress in containing the HIV epidemic worldwide. A few countries, primarily in Southern Africa, have met the UNAIDS 95-95-95 goals. This means 95% of people living with HIV know their status, 95% of those are on treatment, and among those on treatment, 95% will have a suppressed viral load. So countries in Southern Africa that have met the 95-95-95 goals are Botswana, Zimbabwe, Eswatini, and the United Republic of Tanzania. And it is anticipated that more countries in the region will meet these goals soon. These include Zambia, Namibia also. So to sustain the goals, these gains that we have made in the fight against HIV, there is a need to sustain and expand the involvement of communities in testing, prevention, and treatment of HIV. The World AIDS Day 2023 theme was "Let Communities Lead," and this was the reason why we had to make this presentation before the World AIDS Day. The United Nations member states pledged to guarantee that at least 30% of HIV service delivery is community-led by 2030. And this, they said, will be accomplished through investment in human resources for health, as well as the required supplies, instruments, and medications. The member states also further committed to ensuring that a minimum of 6% of HIV resources be directed towards social enabling activities such as advocacy, political and community mobilization, community monitoring, public outreach, and rapid HIV testing and diagnosis programs. Human rights initiatives such as law and policy reform and the reduction of stigma and discrimination will also be included. In 2021, the United Nations Political Declaration on HIV and AIDS reaffirmed that community-led organizations should deliver 80% of HIV prevention services for populations at high risk of HIV infection, including women with those within those populations and and that community-led organizations deliver 60% of programs to support the achievement of societal enablers by 2025. The advantages of community-led responses are that when programs are community-led, clients' needs are addressed holistically. Community involvement may also raise the quality and adoption of HIV services by bringing accountability closer to the level of service provision. And community-led interventions usually enjoy the trust of the community members. And the communities feel a sense of ownership if they are involved, and this enhances the likelihood of the success of the interventions. Community-led interventions can be easily adapted to changing contexts and policy priorities. However, it should be noted that having interventions that are community-based is not sufficient for producing improved outcomes. Interventions must be peer-led, of high quality, and possess a strengthened capacity through skills training to ensure stronger community-endorsed outcomes. What should be noted also is that community responses to HIV do not exist in isolation from health and societal protection systems. These community-based interventions can simultaneously provide the support that community members need and link them to the health system. The interventions can work in synergy with the health system to meet demand, especially where the health system does not have capacity or is unable to reach populations, especially key populations. These linkages augment community services within the health system, and they provide a social, protective, and empowering role, ensuring that a community's rights to health are advanced. Community-led response activities, these are divided into one: advocacy, campaigning, and participation in accountability. Participation in decision-making and monitoring mechanisms. Communities can be involved in resource tracking and monitoring. They can also be involved in meaningful engagement with national AIDS councils, country coordinating mechanisms, and other monitoring and coordination bodies. They can also participate in the design, implementation, monitoring, and evaluation of policies and programs, including enforcement and impact of laws. They can also be involved in securing accountability and fulfilling a watchdog role. The communities can also be involved in advocacy and campaigning to improve access to services, campaigning for reduction in cost of treatment, overturning restrictive laws, especially those against key populations, and securing funding for HIV services. They can also be involved in advocacy and campaigning to protect and advance gender equality, the right to health for all, the rights of key populations, children, and young people. And the communities can also campaign to change attitudes, combat stigma, and improve levels of HIV-related knowledge and rights literacy. The second activity is community-based service delivery. Communities can also be involved in HIV prevention. They can be involved in distribution of prevention commodities like condoms, delivering behavior change interventions, and as far as mother-to-child transmission is concerned, they can link pregnant mothers to care. They can be involved in adherence support, delivery of antiretroviral therapy, home-based care, and services for key populations through specifically designed combination prevention services like harm reduction, peer education, integration of prevention services into sexual and reproductive health and rights services. They can also be involved in confidential and voluntary HIV testing and counseling. These testing services can be done at community level for the general population. They can also offer counseling, and for those who test positive, they can be linked to care. They can also be peer support in assessing testing, especially including home testing and counseling, and in coping with results. Communities may also be involved in counseling, different types of counseling. In HIV treatment, Communities may be involved in the distribution, in the delivery of antiretroviral drugs and other medications that are required by people who are HIV positive. And some community members may be trained actually to provide treatment education to people living with HIV and also treatment services, especially for key populations. They may also be involved in services addressing co-infections like TB and hepatitis B, and they may also provide adherence support. Communities may also be used to create a demand the demand for services and the uptake of services. This is especially important when we are looking at new technologies that are coming in, like long injectables, like the dapivirine vaginal ring. We look at multi-purpose technologies. All these need awareness by the communities. So if the communities are to know which services are available, some community members should be able to spread the word to them. And the community members may also mobilize their peers for demand creation and to broker access and referral for services. Community members may also be involved in palliative care, including home-based care, psychological support, care for children and families, and economic empowerment and income generation. Community members may also be involved in programs to reduce stigma and discrimination, provide services that address and end gender-based violence, legal services, and legal and human rights literacy. And community, especially community health workers, may also community health workers can work both within the health system and outside the health system. They can actually be used to help communities understand adherence issues. Also, they can be involved in the distribution of the medications within their communities. So community health workers provide, they act as a link between the health systems and communities on issues such as HIV, and also other issues like sexual and reproductive health and rights, and many other health issues. Then communities may also be involved in community-based research, what we call participatory community-based research. They can be involved in research on stigma and discriminations faced by a community or a population group.
Hi, Doc, if you can hear us, we've lost connection.
We can't hear.
No, he's dropped off the call, but the audio's dropped. So we might need the tech guys
Hello?
in, right? Can you work out what's going on that's wrong?
Hello?
Dr. Moyo, are you back?
Can you hear me?
We can hear you again now. Sorry, you dropped off probably about
okay.
a third of the way through the slide.
Oh, okay. The slide on
Community-led responses,
before this one.
activity number 4.
Oh, okay. So
It's the
I was
slide
talking
that's
of
on the screen.
participatory community. Okay. I was talking of participatory community-based research, where I was saying communities can also be involved in research on stigma and discrimination faced by a community or a population, research on stigma and discrimination experienced in accessing services, research on gender norms and gender equality. They can also be involved in monitoring, documenting, and analyzing human rights violations, and also research on the burden of disease and HIV-related vulnerabilities for population groups and communities, research on vulnerability factors to HIV for different population groups or different geographical locations, and research on available programs, including treatment and prevention, the gaps and barriers of access, needs assessment, especially for key populations on priority health and social care needs and services, and also policy framework analysis and how it affects ability to access equitable and quality treatment, prevention, and care support. Communities are pivotal also in research on new treatment and prevention technologies. Like I was talking of the new technologies that are coming in, it's quite important that communities are aware of these, since they are the ones who can sensitize the other community members. And communities may also be involved in participation in ethical review boards and in deciding what and how research should be conducted. They may also be involved in research to reach key populations with community and rights-based policies and programs by estimating population sizes of these key populations, looking at the modes of transmission, related research, research on gaps and barriers to access for services and human rights, needs assessments for key populations, and evaluating policies and programs aimed at reaching or affecting access by key populations. Sorry, my slide is not, is going backwards. Let me see.
Dr. Moyo, if you need any help, just Pride is a
Yes.
techno genius, and you and I probably are just simple doctors. So feel free to ask me for help.
My slides are, I think they're frozen or something. Yeah, okay, now, okay, that's fine. I was now on community financing, where we are saying communities can be also involved in the financing of HIV services. This might be done through on granting, or what we call forward granting, where if a community has substantial capabilities and strong track record and have a grant, they might be able to, under a sub-grant agreement, provide grant funding to smaller communities and associations to strengthen or scale up their activities relating to the implementation of a project. They can also be involved in resource mobilization and also community financing initiatives. One of the community financing initiatives is the community-based insurance, which has been implemented in a number of countries in Africa, like Rwanda, the United Republic of Tanzania. This is where is a type of health funding that is operated by an organization other than a government or for-profit private company that provides risk pooling to cover all or parts of the cost of healthcare services for a community. And this community will have they will share common characteristics, like they say they stay in the same residential area. It emerged around the 1980s as a way of financing healthcare in low-income countries, and it frequently provides limited coverage to population groups that are difficult to reach. This model also is appropriate for providing health insurance for people with little or no protection from other sources, especially those who are in the informal sector of the economy in developing countries. The main characteristics of community-based insurance are that the affiliation is voluntary and it operates on a non-profit basis. It uses prepayment mechanisms for raising funds, and the pooling of risk and funds is done at community level or for a group of people who share similar characteristics, and the membership premiums are often similar for everyone and are not dependent on an individual's health risk. Entitlement to benefits is usually linked to paying contributions, and members participate in decision making. Let's look at the barriers to community-led responses. The main problem is funding constraints. I'll talk a bit more about it as we go. There's also social stigmatization, discrimination, and violence, and also in some countries, repressive laws and policies. When I was doing this, preparing this presentation, I did a scoping review of primary studies conducted in Southern Africa and published in English between 2013 and 2023. I came up with 13 articles after removing duplicates, title and abstract screening, and full text screening. And among these studies, there were 3 conducted in South Africa, 3 in Zimbabwe, 2 each for Malawi and Tanzania, and 1 each for Eswatini, Zambia, and Mozambique. 11 of the studies were quantitative. 1 was a mixed method study, while another was a qualitative study. These are the studies. Most of them, like I said, were quantitative, and the populations that were involved here, most of them were adults, except maybe 1 which looked at the adherence in children. So the interventions in Southern Africa that were implemented in Southern Africa in the last decade in published articles include community mobilization for treatment as prevention, a peer-based education program on risk behaviors, adherence clubs and decentralized medication delivery, community conversations in facilitating local HIV competence, community leader engagement, community days and peer groups, and community-led HIV self-testing, peer group intervention to increase HIV prevention knowledge, community-based adherence counseling and intensive follow-up, community savings participation, community-based HIV testing and ART linkage, community-based mobile and index HIV testing by peers and linkage to ART, and community adherence and support groups. I'm not going to, I'll summarize this I'll summarize this after these slides. These are the outcome findings for these community-led responses that were implemented in Southern Africa. Most of them you'd find these are the main findings where we are looking at the intervention group and the control group. Like if you are looking at the first one, they were comparing the control group is those who receive the standard of care and those who are included in a community-based intervention. And it was discovered, like in the first study there, that there were more people who were likely to know their status to be on antiretrovirals and to be virally suppressed among those who were on community-based interventions compared to those who were on the standard of the standard of care. Right. So among all those studies, what came out is that there was an improvement in knowledge about HIV and AIDS in community-led, more in community-led intervention groups than those who received standard of care. There was also a reduction in risk behavior, improved self-efficacy in sexual relations, increased disclosure of HIV status among partners, and an increase in consistent condom use. There was also an increase in HIV testing, an increase in linkage to care, and a significantly higher ACT initiation in the first 3 months after community-led HIV self-testing compared to the standard of care. And treatment adherence among the community-led intervention groups also improved significantly when compared with the standard of care groups. Among participants on HIV treatment who received community-led interventions, there was a higher retention in care compared to those in the standard of care groups. Community-led interventions also led to an increase in viral suppression among participants who were taking antiretroviral therapy, and the quality of life among participants in community-led intervention groups was better than those in the standard of care groups. Community-led interventions also led to better coping of living with HIV among participants and improved the critical thinking on how to solve problems caused by HIV. Community-led interventions also reduced HIV stigma, motivated and inspired communities to help people living with HIV, and inculcated a sense of community and common purpose among community members. Before we go to the take-home messages, examples of community responses to HIV that reached significant proportions of communities they serve in Southern Africa include the Churches Health Association of Zambia in Zambia. This is one of the second largest provider of health services in Zambia, and it provides more than 50% of health services in rural areas. And between 2005 and 2014, it provided antiretroviral therapy to over 86,000 people living with HIV. The other example is Mothers to Mothers in South Africa. This organization, they mentor mothers, they advise mothers and support the pregnant mothers and support them, that is those who are living with HIV, and they accompany them through the process of accessing prevention of mother-to-child transmission services. They also train, empower, and employ thousands of women living with HIV as mentor mothers. And they frequently implement the model through existing community-based and faith-based organizations. And they reach over this, the mother to mothers, South Africa has expanded to other countries, and it is thought to have reached over 2 million women living with HIV in 9 countries. The other example of a community-led response that has had a significant impact is the coordinated advocacy by civil society organizations in Namibia to increase investment for community responses. Since Namibia has reached the upper middle income status and the key donors are phasing out, as a result, key donors are phasing out their financial support to HIV. So in the Namibia context, 90% of HIV and AIDS funding comes from PEPFAR, USAID, and the Global Fund. So when these organizations reduce their funding, it is expected that 80% of what they are providing now, it is expected that the funding will decrease by 80% in the coming years because of the status of the country as an upper middle class. So it means now civil society organizations, if no adequate resources are found elsewhere, most of these civil society organizations that are involved in HIV might not be able to continue working. As a result, about 9 civil society organizations, including Positive Vibes, used a strategic investment framework to engage in dialogue with the government and demonstrate areas of comparative advantage of civil society in the HIV response and where investment needs to go as far as HIV is concerned. So in 2012, Positive Vibes organized a workshop on the strategic investment framework for 27 civil society organizations in Namibia. And following this workshop, they formed a network and a steering group committee to coordinate their engagement with government. The network developed a civil society position paper that outlined how, using the strategic investment approach, civil society can act as a key government partner in the design and delivery of an effective HIV response. This paper served as the basis for securing and developing a dialogue platform with government, as well as supporting a coordinated action by civil society on investments for community responses to HIV. As a result of civil society advocacy, the strategic investment approach is now completely integrated into the review process of the National Strategic Framework, and it is considered to be one of the concepts underpinning the process. So these are some of the examples of successful community-led responses. So the take-home messages today for this presentation are that even though Southern Africa has achieved great strides in containing the HIV epidemic, community involvement is still necessary in all HIV prevention, treatment, and care initiatives in the region. Involving communities brings about several advantages, such as increasing program sustainability, guaranteeing trust with local populations, and fostering accountability. Peer-based programs, adherence clubs, community conversations, support groups, community leaders' involvement, community-based HIV testing, and art linkage are examples of community-led interventions that were implemented in Southern Africa in the past decade. The outcomes of these interventions include increased awareness of HIV and AIDS, decreased risk behavior and stigma related to HIV, increased disclosure of partners' HIV status, increased use of condoms consistently, increased testing for HIV, linkage to care, adherence to antiretroviral therapy, retention in care, and viral suppression, as well as an enhanced quality of life. Thank you. These are the references that I used for this presentation. Thank you. Back to you,
Thank you.
Dr. Jackie.
Thank you very much, Dr. Moyo, for a very insightful presentation. And obviously, having just been to ICASA, many of the points that you raise are extremely valid. We have some very knowledgeable on this call. Dr. Chimbateki is on the call, Professor Ndurukwa is on the call, and I'm hoping Farai Machinga, who is the Acting Executive Director of ZNF PNA, which is the Zimbabwe National Family Planning Council, ZNFPC, sorry. So if he is on, he's certainly responsible for managing several youth clinics around the country. So I would invite those three speakers to unmute themselves and perhaps comment. I'm sure Professor Ndurukwa will have a comment on how the economy is affected when we get community engagement. And I know Dr. Chimbatete's passion is to not treat viral load, but to treat people with HIV. So I would invite Dr. Chimbatete first to unmute his mic. That doesn't seem to be working. Is Professor Ndurukwa on the call? I'm having a bit of difficulty unmuting and muting, so there may be a technical issue on this call. So, Dr. Moyo, I'm going to ask you two questions that come from a patient who has HIV and who asked me these questions at ICASA. And his feeling is that there should be more interaction with people who go out to youth centers and educate young people with HIV. His question at the time came after Dr. Tedesi presented on COSATAF, or the use of TAF instead of TDF. And his question really was that while he understands why DTG is required to bring down the viral load very quickly, why have young people not been informed of the long-term side effects? Because somebody who is on combination therapy and they are 22 years old may well be facing a hip fracture when they're 40. So I'd love to hear your comments on how you envisage we can get those kind of messages out to the youth centers.
Thank you, Dr. for the question. I think some of the interaction with the youth and the communities are a bit usually for us to improve and send these messages to these communities, we should involve them even at the point of research when we are researching into some of these drugs, the side effects and everything. And the people who are involved in this then will be able to act as agents now to inform the communities about the advantages and disadvantages of some of these medications. It's the same story here, like you find if you look at PrEP and PrEP, for example, there are some communities where they don't even know what PrEP is or what PrEP is. Yet these are easily available in some of the, like here in Namibia, at the government hospitals. So the important thing is about sending this message to the communities. And how do we send it to the communities? It shouldn't be just the healthcare workers, but to involve some of the members of these communities so that they act as our agents in explaining some of these things to the patients themselves. On the issue of TAF and TDF, initially, yes, you see the information comes in, but sometimes you have to, there has to be more research before you say, let's move to this drug or that. So I think that is one of the gaps where something might come up, but there is more evidence required before you can actually send that message to the community. So when someone reads that, okay, this information was there in this year, in maybe 2013, but it's not there. It's only now that we are hearing about it. Sometimes it might be just an issue of where maybe there was not enough evidence at that point and people were not comfortable explaining that to the patients, but were waiting, the healthcare workers, but were waiting for more evidence from other studies to come up with a point or some guidelines, like especially national guidelines, who guidelines to direct us on what to do in these circumstances. Thank you.
Thank you. That was very useful. And sometimes when we brainstorm on these sessions, we come up with solutions. So Intellectus Campus is essentially an accredited, or it can accredit learning. And one of the things that would be a possibility is we could do a certificate in HIV education, which required continuous update, possibly once a year. And we could teach some very smart youths. Many of them are university students. Many of them have degrees in biological sciences. And we could potentially train them and give them a certificate, and they could go out and teach people who would teach people who would teach people. So one of the questions I would ask is, do you think that it would be possible to get funding for that sort of a project?
My opinion will be, especially if we look at the outcome of the project, where communities are going to be to know more about maybe prevention measures, treatment options, and all that, it's likely to be funded, yes. But it will depend on how the proposal is written and the motivation on to the donors. But it definitely is something that might receive funding.
Excellent. Thank you for that answer. I saw Farai's name come onto the screen. Can you unmute Farai if you're on the call? Pride, are you ensuring everybody stays muted? Can you make sure that people can unmute? Yeah, I think we've got a problem with people unmuting. So with regard to the youth clinics, in Zimbabwe, and those youth clinics are often not known about by many of the GPs in the region. And I think there's huge power in those youth clinics because they already educate on things like how to build a greenhouse, how to grow your own food, how to, they have how to cook in a healthy manner, and many other simple courses that teach them basic life skills. And then they would be a wonderful platform on which to launch these kind of education programs that would be community-led. The curriculum or the actual course could be written by several people, and some of whom are on this group, and it could be a 1 or 2 day course. And we have discussed rolling it out through all the youth centers so that everything from prep all the way through to differentiated service delivery would be covered. I'm not sure if you have a similar kind of setup in Oshakati, but I would be interested to know whether Namibia has a similar setup.
In Oshakati, no, but in other places, I'm not very sure, but I can check.
Okay, thanks very much for that. Does anybody, if anybody wishes to ask a question, can you please raise your hand? I think there's a problem with unmuting. As you know, I'm not very good with technology, so I am not very good at fixing this problem. Dr. Moyo, I'd like to ask you a question from my point of view. And that is, I believe they're going to be starting to manufacture PrEP in South Africa, the injectable form. And I would be interested to know your thoughts, because the barrier to injectable PrEP currently is financial. And if it is manufactured within Africa, do you think that this will make a difference to people using PrEP and to...
Hello, Dr. Jake.
Yeah, I can hear you.
I didn't hear the last part. Yes, I think you went mute a bit.
So the question really is, do you think that the production of PrEP within South Africa will reduce the cost? And the second question is, obviously injectable PrEP you've presented before is a much more acceptable option, and people invariably arrive for their 2-month appointment. Do you see any downside to injectable PrEP?
Oh, okay. On the cost as far as production in South Africa is concerned, I think there has to be one thing that we have to look at is the companies that are producing, whether they are producing in South Africa, in India, or elsewhere. Have they waived their patent for the production of the drug? If they haven't, then it won't have an effect on the cost of the drug. However, if the patent has been waived, then that means generics can come in, and if they are produced in Africa, like in South Africa, it might actually be cheaper compared to when they are produced elsewhere. So I'm not very sure, because initially I think the company had said they were going to waive their patent for the injectable for PrEP. But I'm not sure whether that has been implemented or it was just something that was said then. That was, I think, end of 2020, I think it was around June 2023. Then the issue of the injectable, yes, it's acceptable, and most people would prefer it than taking a tablet every day. But the issues then that might be problems with the injectables, one is the healthcare workers. Right? Are they going to be like accessibility? Are we going to get these injectables everywhere in every clinic in each country? That is one of the things that is questionable. And the other thing also is, in some countries, injectables are only given by nurses and doctors. So in this situation, that means if a clinic has a nurse aide, they are not going to be able to give the injectables, meaning that some people are not going to be able to access it. That's one. The other issue also is the downside at the moment is also the issue of cost, that it is very expensive compared to the oral. So that is another downside to it at the moment. Then also we look at, even if it's acceptable, we'll find there are issues now of resistance that people are worried about. That like it takes, if someone gets an infection while they are on the injectable, they are less likely going to, the HIV test is going to take longer to be, the HIV is going to take longer to be detected. And as a result, there is worry that they might be resistant because of that. However, to counter that, there has to be improvement in the types of tests that we do for these patients who will be on injectables when you are testing them for HIV. So those are some of the downsides that come to mind. There might be other barriers, but these are the ones that come to mind at the moment. Thank you, Dr.
Great,
Jake.
thank you. Thank you very much for those answers. It's very enlightening, because many of us have never seen a vial of the injectable PrEP. One other question I wanted to ask you is, apparently it's quite a painful and quite a thick injection. And we had a discussion on training nurse aides and having a specific certificate, because nurse aides are not allowed to inject. However, we are aware that in some countries, they have used people who are not nurses and trained them to inject, and they often do a much better job than doctors and nurses who are in a hurry. So I'm not sure if you have any data or if you have any opinions on treating non-medical people to inject, and any comments on whether this injection is painful and whether that is a potential deterrent.
Yes, on the painful part of the injection, yes, they say it's painful, but it tends to improve as the patients receive repeat doses. Maybe because they are used to the pain, but injection site pain is one of the deterrents to some patients to continuing with the injection. On the use of non-medical staff to inject, I think it's possible, provided even if the patients are being injected by non-medical staff, but there is a healthcare worker like a nurse or a doctor, especially a nurse in our setting in Southern Africa, okay, at a clinic, who will be able to attend to these patients if there is a reaction to the medication. Because remember, the injectable, actually, the pamphlet tells you that after injecting, these patients should remain at the healthcare facility for at least 10 minutes, which is another downside to say, do we have the facilities to keep these patients? Maybe we can say they'll stay outside on the bench at a clinic or something, but they should remain at the clinic for at least 10 minutes, especially the first dose. So basically, we are worried about maybe there might be this side effect or that. So even if we say non-medical staff can inject these patients, but we should have someone who should be able to address side effects if they do okay in these patients. That would be my opinion on that. Thank you.
Great, thank you very much. One of the models we're looking at is the Royal Flying Doctors in Australia, and they have what they call a medical chest, which is A to Z and 1 to 10. And doctors on a phone can, with a telemedicine system, can talk them through, for example, injecting adrenaline in an anaphylaxis situation. But the criteria is the person who has the keys to that chest has to have been trained to inject into the lateral thigh, which is probably an area that is very difficult to get wrong, because you're not going to hit any major blood vessels and nerves. So I think that will be a very interesting thing going forward to explore, because the bottleneck certainly in Zimbabwe with care is the number of nurses, and the fact that many of them are overloaded, and they are, because our nurses are very well trained, I think that they are welcomed with open arms in Europe and the UK and Australia, and we are losing a lot of very, very skilled staff. So one of the concepts is to follow the Royal Flying Doctors training module, which is specifically to teach people who have access to a medicine's chest to inject. The important thing is, in that medicine's chest is an anaphylaxis kit, which people are also trained on. So they train to inject adrenaline, promethazine, and hydrocortisone in the event of a reaction. So I think these are all things that could very easily be discussed with communities. And we have some very influential, very passionate people in Zimbabwe, including Professor Rudo Mataza, who runs a Musawara outreach group. And hopefully many of these ideas will be able to be rolled out through this sort of a group and monitored. So I think there's exciting times ahead, and the concept and solutions for African problems will become the theme, hopefully all the way through to 2030. So Dr. Moyo, I would like to thank you enormously for your time and for your wonderful expertise and for the contribution you are making in Northern Namibia. Thank you for that. And thank you to all our attendees for listening. If anybody has a burning question, we can answer it. It seems that that Farai is on another call, which is taking longer than he thought. So I don't think he'll be able to join us. But thank you, everybody. And here's to 2024 and a very productive and prosperous new year.
Thank you, Dr. Jackie.
All right, Pride, we can stop recording. We will leave the registration link open for the next 5 to 10 minutes. I'm just looking at the time here. And we'll leave it open for another 6 minutes. So please register if you have not registered yet. And we will close the session down. I will stay on the call. Pride will stay on the call. Dr. Enos, you're welcome to stay and chat or leave the call. And once everyone is registered, we will close the link.
Okay, thank you.